Hello, this is Chris Frigno. This discussion will go over the axilla and the arm. The first order of business is probably to discuss what is the axilla. Well, the axilla is an area that is the transition zone between the posterior triangle of the neck, or the neck in general, and the arm itself. So it's essentially this armpit area, if you will, and this lateral chest area. Here we can see the general location of the axilla as an area that sits somewhere between the clavicle and the ribs, the coracoid process and the ribs, and the humerus and the ribs. It's going to serve as the transition zone of neurovascular structures as they go from the neck into the arm. Here we see the boundaries of the axilla. I don't want you to sit and memorize the boundaries. I only include the slide to be complete, so if you have an interest in understanding where the exact boundaries are, you can refer back to this. Again, you don't have to memorize the exact boundaries. The superior entrance to the axilla is called the axillary inlet. So the axillary inlet would be this area between the clavicle and the upper margin of the scapula and the first rib. Since the pectoralis major forms the anterior wall of the axilla is posterior to this pectoralis major. And the axilla sits anterior to the posterior shoulder muscles, the subscapularis, teres major, and latissimus. The axilla is, again, lateral to the ribs. Overlying the ribs is an extremely important muscle called the serratus anterior muscle. It arises from the first 9 ribs and extends posteriorly to attach to the scapula. Let's take a look over here. We can see the serratus muscle attaching to these first 9 ribs and extending back and attaching to the medial border of the scapula, but on the anterior surface, which is what this red dotted line is indicating. So you can imagine the line of pull of this muscle is in this direction, but throughout the medial border of the scapula. Therefore, this is a very strong stabilizer of the scapula where it holds the scapula up against the rib cage. It can also bring the scapula forward along the rib cage, so it's a powerful protractor of the scapula in addition to the other protractor that we talked about, which was the pec minor muscle. The serratus anterior is innervated by the long thoracic nerve. Recall that this long thoracic nerve came off of C5, C6, and C7 to travel down along the thorax to innervate this serratus. Because the serratus is such an important stabilizer of the scapula, again, keeping the scapula against the rib cage, any dysfunction of the serratus anterior can lead to something called winging of the scapula. So here we see a posterior winging of the right scapula. Here we see it on the left side, and then here we see it on the right side. This can be due to various reasons. One common reason would be because of a lesion to the long thoracic nerve, or the innervation of that nerve. Because the nerve is going along the chest wall, any fracture to a rib in this area, or you could imagine we have breast tissue here, and if the surgeon goes in to remove the axillary part of the breast, the long thoracic nerve can get lesion in that area. When assessing a patient for upper extremity weakness, particularly in the shoulder, you want to assess if they have a competent serratus anterior, and there's a couple ways to do this. One is to simply just ask the person to flex their shoulder and feel or palpate their scapula on both sides. If their shirt's off, you can visually inspect it as well. They should have a scapula that looks something like this, where again it's pressed up against the rib cage. Another good test is to get the patient to put their hands on the wall and do a wall push-up. The reaction force of the wall coming back through the arm will push this scapula posterior if there isn't good serratus anterior control. So here on this slide we can see the long thoracic nerve that I've drawn in here coursing underneath the muscle and the breast tissue. So you can imagine going in and excavating the breast tissue out for a mastectomy, along with the underlying muscle in a radical mastectomy. It's quite challenging for the surgeon to preserve this nerve. So now that we've defined the axilla, we should probably take a look to see what courses through the axilla, because that's really the important part. Here we can see a general outline of the axilla formed by the artist by pulling out the pec minor muscle and the pec major muscle. Here's the distal part of the pec major muscle. So we can make out this outline, and we can see a vein, an artery, many branches of that artery, as well as this huge network of nerves of the brachial plexus coursing through here. Here we can see that long thoracic nerve diving down, the thoracodorsal nerve going to the lat, the 5 terminal branches of the brachial plexus. The letter M would be right up in this area. You can see a lateral cord over here and a medial cord over here. And this down here, this yellow one that's hooking around here into the armpit, would be the axillary nerve, while the radial nerve is coursing underneath the axillary artery. This is a top-down view of the axilla. So inside this red outline would be all the contents of the axilla. This often benefits students just to see a simple breakdown of the axilla and how it relates to the arm. So this is the skin of the arm. This is the skin of the wall of the thorax. And so this area would be the armpit. So here we see again the axilla, but now we can have the pec minor showing. So we see almost all the contents coursing posterior to this pec minor, between the pec minor and the lateral wall of the thorax. So this slide says exactly the same thing, just summarizes. And the same with this. This is just suggesting that this brachial plexus is coursing through this posterior triangle, and then once it passes the clavicle, it's entering the axillary inlet just behind the clavicle and going through the axilla.
Because these areas are generally very small and have lots of structures coursing through them, there's the potential for compressions to occur at any of these regions. So there's 3 general regions where thoracic outlet syndrome can occur, which is a bit of a misnomer. It should probably be called thoracic inlet syndrome because structures are generally coming into the inlet. But either way, let's take a look. So we have this interscalene area. Remember, we have the anterior scalene and the middle scalene, and between them is the interscalene area, and that's where the roots or maybe the trunks of the brachial plexus are coming out. Underneath the clavicle, between the clavicle and the first rib, is the costoclavicular space, so that would be up in here. And here's an inset showing this costoclavicular space. And then underneath the coracoid process, especially if this scapula gets tilted forward, you would get compression in the subcoracoid space. Now, as you can see here, most of the time it's the nerves that get pinched. So even though we notice a very large vessel here and a very large vessel here that look to be extremely vulnerable in this area, the nerves of the brachial plexus are much more often impacted. So this slide is just highlighting this interscalene triangle where the brachial plexus could get impinged. It's also a nice image where you can see some relationships where you see the subclavian vein and ultimately the axillary vein much more superficial than the subclavian artery or the axillary artery. You can also see the anterior scalene coming into the first rib and separating the axillary artery and vein. Thirdly, you can see the brachial plexus at this point coursing posterior to both the vein and the artery. You could start to really make out this interaction between the first rib and the clavicle. We call this a chopstick configuration. You can imagine that the 2 chopsticks can start compressing things. So here we see that chopstick configuration where both the artery and the brachial plexus are vulnerable. So this would be in the costoclavicular space. Looking inferiorly, we can start to make out this subcoracoid space as well, and we can see that here with an issue with either a very tight pectoralis minor muscle that could compress the vasculature. It's usually the vasculature in this area. Or if there's a tilt again in the scapula, it could compress either the axillary artery or a part of the brachial plexus. So let's move down from the axilla into the arm. Here we can see a cross section of an arm, and in the extremities we'll look at cross sections quite a bit. So here we can see the humerus. Up here would be anterior, and down here would be posterior. So this compartment here, shown in a slightly brighter color, would be the anterior or flexor compartment, and then this region would be the posterior compartment or the extensor compartment. In the arm we have skin, and we have a very light superficial fascia, and then we have a deep fascia shown here in blue. And in this deep fascia you'll notice that there are some indwellings that sits between the muscles. And it's a little hard to tell from this image, but there is thickenings of these indwellings that attach the deep fascia into the bone on the lateral side. This is called a lateral intermuscular septum. And then medially, we have a medial intermuscular septum that wraps around this neurovascular bundle. And so we have a lateral and a medial intermuscular septae that separate the anterior compartment from the posterior compartment. And why do we talk so much about compartments? Well, developmentally, there is typically a single nerve that is brought down into the compartment to innervate the muscles of that compartment. So here we would see the musculocutaneous nerve that's coming to innervate all the muscles of the anterior or flexor compartment. And posteriorly, the radial nerve would be coming down to innervate all the muscles of the posterior compartment, primarily the three heads of the triceps. Also note that there's a blood supply to each compartment. So here we can see that deep artery of the arm, in other words the deep brachial artery or the profunda brachii. And then in this compartment, although it's wrapped up in this intermuscular septum, is the brachial artery that's going to end up serving this compartment. So one strategy of remembering, at least remembering the general function of a muscle, the innervation and its primary blood supply, is to just compartmentalize it. So if you can say that a brachialis muscle, for instance, is in the flexor compartment of the arm, or it's on the anterior surface of the arm, then you could say it must be a flexor. And you can also pair that compartment with a nerve, so it must be innervated with the musculocutaneous nerve. Here we show a similar slide, and it's a summary slide showing the anterior compartment now facing down. This would be the anterior and this would be posterior. It lists the muscles, the biceps brachii. We're going to see a brachialis and a coracobrachialis. It lists the nerve supply for each of the two compartments. I also want to stop for a second and talk about general nomenclature. So when we mention the word arm, the arm will be this region, so the area between the shoulder and the elbow. The forearm is between the elbow and the wrist. And of course the hand will be everything distal to the wrist. So in the arm, we have the flexor and extensor compartment, or the anterior and ultimately the posterior compartment. Here we see the flexor compartment and its three muscles. Superiorly, we have the coracobrachialis. Now, let's take a look at the name, and we can break down this muscle. Coraco, meaning it emanates from the coracoid process, and brachialis, meaning it's going to attach also to the brachium, or the humerus. So here it is going from the coracoid to the humerus. What joint will it act at? Well, it'll act at the shoulder joint. If a muscle crosses a particular joint, it will act at that joint. If the muscle doesn't cross a particular joint, it won't directly act at that joint. However, realize that sometimes a muscle will act indirectly at a joint by moving a proximal joint or a distal joint. But that's a little too complex for this course. What joint will it not act at? It will not act at the elbow because it doesn't cross the elbow joint. With regards to function, it's nice to look at these images that take the muscle away and just put in some lines connecting points of attachment. Unfortunately, the coracobrachialis is not included in this, and I'm not sure why. So let's draw it in. We have the coracoid process, and emanating from that coracoid process, it inserts onto the humerus. Well, it's going to cross the glenohumeral joint, so it's going to act at that glenohumeral joint. It's crossing anterior to the joint, so it's going to be a flexor. So it will be a flexor of the humerus at the shoulder joint. We can add in an arrow to show that it's going to be pulling up this anchor point up towards this anchor point. Now certainly the humerus could be a stable structure and the scapula could be the movable structure, but most likely this will be the stable structure and this will be the moving structure. Moving inferiorly, we see this muscle, the brachialis. So once again, we now can use this line and draw an arrow saying that if this is the stable segment, it'll be pulling this segment up. What is this segment? Well, look, it's attaching directly to the ulna, so it's going to be pulling up at the ulna, so it'll move the ulna at the elbow joint, so we'll have elbow flexion. Looking at the biceps muscle, here we can see the biceps. Biceps means two heads. So we have the long head emanating from the supraglenoid tubercle and the glenoid labrum, and descending down and through the intertubercular sulcus, ultimately going all the way down to attach onto the radial tuberosity on the radius. The short head emanates from the coracoid process along with that coracobrachialis muscle, and the short head descends down, joins up with the long head to also insert onto the radial tuberosity. Since it crosses the elbow joint, it's going to be a flexor of the radius at the ulna, so we'll put a little arrowhead up this way. So it'll flex the elbow, or the radius at the elbow. But because the radius also moves in supination and pronation, if the radius was pronated, in other words, was crossed over the ulna, it could supinate it. So once again, looking back up at the coracobrachialis, we see it coming from the coracoid process into the humerus. We can put an arrow indicating that it's going to pull upward on the humerus, and therefore it'll produce what action? Shoulder flexion. Now you can see, we see adduction as well, because you can imagine that because it comes at an angle and it's somewhat medial, if the arm, if the humerus was abducted, then that muscle would be able to pull it that way in. So here we can see the coracobrachialis right up in this area, medial to the biceps brachii. Here is the letter M of the brachial plexus, so this would be the musculocutaneous nerve, and we can see that musculocutaneous nerve piercing directly through coracobrachialis. It's much more apparent here when you take away the biceps muscle that the musculocutaneous nerve pierces and courses directly through the coracobrachialis muscle. Let's continue following it up underneath the biceps brachii. And so that's not apparent so much on this picture because the biceps has been taken away. But you notice we don't see the musculocutaneous nerve here because it's up underneath the biceps brachii. We'll ultimately see it come out right here, although we don't see it in Netter's picture. Here we can see it coming out as a newly named nerve, the lateral cutaneous nerve of the forearm. So once it's done innervating all three muscles, the nerve becomes the lateral cutaneous nerve of the forearm, or the lateral antebrachial cutaneous nerve, and it's going to serve cutaneously the lateral forearm. Here again we see the biceps, the long head of the biceps coming from the supraglenoid tubercle and the glenoid labrum, extending down to insert onto the radial tuberosity. And we have the short head coming from the coracoid process extending down also onto the radial tuberosity. Of course, because it crosses the elbow, it's going to be a flexor of the elbow, and because it's onto the radius, it can also supinate. Now remember, both of these heads are also crossing at the glenohumeral joint. Crosses anterior to the glenohumeral joint, so it's going to be a flexor of the shoulder, or flexor of the glenohumeral joint. But also note that this long head especially is somewhat lateral to the glenohumeral joint, so it could also act as a very mild abductor, but that's of much lesser importance than the flexion of the shoulder. So let's see what we have here. So we have a elbow flexion, we have flexion of the shoulder, and then we have the supination of that radioulnar.
So here's that long head of the biceps going through the intertubercular groove. And here it is coming into the supraglenoid tubercle. Now in this image we can see that it gives attachments into the superior labrum, and here we can see that as well. But with forceful contraction of the biceps, you can get a tear of the superior labrum off of the glenoid fossa because of this insertion of the biceps tendon. So here we can see that magnified. So this would be a slap lesion, a superior labrum tear from anterior to posterior. So here on the left is a situation where you might get a forceful contraction of the biceps. So here you can see a something with some substantial weight, or we could replace this piano with let's say a 2-year-old child who is descending down, let's say as a result of a fire in a building, and that child is descending down. The child weighs 20 pounds, but is accelerating at 9.8 meters per second, and therefore when the baby reaches this man who's going to save the baby, the force is so substantial that the biceps tendon either ruptures or that labrum and biceps ruptures, and you end up getting a deformity here because of that rupture. So the biceps tendon has slipped down, resulting in a deformed biceps muscle, or a slippage this way. This deformity is called a Popeye deformity. Now realize that the biceps can also rupture inferiorly here at the radial tuberosity, and therefore a contraction of the biceps, if there is one that can be had, the head of the biceps would migrate upwards as a result.
The brachialis is a very large muscle that sits deep to the biceps brachii. You can see the large footprint of the muscle on the humerus. Remember, it's going to extend down from the humerus onto the tuberosity of the ulna. It's going to be a very powerful elbow flexor. And you can see it inserts under the ulna, not the radius, so it doesn't do supination or pronation, and it doesn't cross the glenohumeral joint, so it only acts at the elbow to flex the elbow.
Now, this is a slide you want to spend a little bit of time with. Again, we can see the M of the brachial plexus here on the left-hand side. Coming off the upper trunk right here would be the musculocutaneous nerve. You should be able to trace the musculocutaneous nerve from its origin, in other words, from the upper trunk, all the way to where it ends. So let's take a look at that. So here we can see the musculocutaneous nerve is going to pierce brachioradialis, and then it's going to course underneath the biceps brachii, and it's going to innervate the biceps brachii, and then we can pick it up here underneath biceps brachii, but on top of brachialis, and it's coursing inferior and lateral, and then it's going to exit out of this area, just lateral to the biceps brachii, close to the elbow. And when it exits, it becomes the lateral cutaneous nerve of the forearm, aka the cutaneous part of the musculocutaneous nerve. Now, which nerve are we talking about? We're not talking about the thick nerve here. We're talking about the thin nerve right here as it continues down laterally. And why is that important? If we look at this image over here, this shows you the anterior or ventral arm and forearm. We can see the green region here on the anterior, and then the green region portion here of the posterior forearm. This is the lateral side of the forearm on both of them. That patch of skin is served by the musculocutaneous nerve, or the lateral cutaneous nerve of the forearm. Let's take a look at the rest of the upper arm. So we'll look at generally everything above the elbow for right now. Here, medially, we can see the medial brachial cutaneous nerve. Now remember, off the brachial plexus, we had three things coming off the brachial plexus. We had the medial brachial and medial antebrachial cutaneous nerves, as well as the medial pectoral nerve. So the medial brachial cutaneous nerve, or the medial cutaneous nerve of the arm, comes off the medial cord and innervates the medial arm, as we see here. The medial antebrachial cutaneous nerve generally innervates the forearm, although in this image we see it coming up right along the ventral arm itself. The radial nerve, here we can see the radial nerve creeping around. It's spun around the spiral or radial groove in the back of the arm. It's spun around the humerus. It's come off the posterior cord. We can't see that back here. And as it's looping around the arm, it's sending off cutaneous branch for the lateral arm. So here we can see that lateral arm as well. Since we're here, we might as well look at the posterior arm. The posterior arm is rather easy. We can see that the radial nerve does most of the job, with the exception here of the within close to the armpit, because the medial brachial cutaneous nerve wraps around a little bit. But generally speaking, the back of the arm is the radial nerve. The front of the arm is the medial brachial cutaneous nerve and the radial nerve. One thing that we should note up here is the axillary nerve. Now, generally, the axillary nerve innervates the lateral shoulder. It's called the axillary skin patch. And often, it's only the size of, let's say, the circumference of a tennis ball in this region here on the lateral arm. Here the artist shows it coming from the posterior shoulder and wrapping around to the anterior shoulder. And that is often the case, but not always. A good understanding of this map is critical when you're evaluating patients. You can imagine that if a patient has a lesion in a peripheral nerve, let's say they get cut somewhere, downstream of that lesion, they might have issues in the cutaneous distributions of those nerves. If they get a cut in the armpit, the medial brachial cutaneous nerve might get lesion, and therefore there might be some numbness or tingling or general absence of feeling, asensory, in this region. And knowledge of that will be helpful in assessing your patient and testing your patient. If there's a lesion in your radial nerve, for instance, let's say there is a fracture of your humerus mid-shaft, and therefore the spiral groove or the radial groove is impacted, might impact the nerve. Therefore, either testing this area or testing this area would be very important. Imagine as that musculocutaneous nerve is coursing up underneath the bicep, it gets lesioned, let's say with a knife blow right here, knowing that the cutaneous distribution over here on the lateral forearm would help you in your clinical assessment. Because of its course up in the armpit, and also the fact that it exits out the quadrangular space posteriorly, the axillary nerve is vulnerable to injury, usually due to compression in the armpit. Improper use of crutches, where the crutch is actually up into the armpit instead of pressed up against the side of the torso, could compress this axillary nerve, or a very high fracture, i.e. in the surgical or anatomical necks, could produce a sharp edge at the bone and produce a lesion within the axillary nerve. Either the compression or the sharp lesion of the axillary nerve could produce a paresthesia in the axillary nerve distribution. The posterior compartment of the arm, or the extensor compartment of the arm, is essentially the triceps compartment. The triceps means it has three heads. We have the long head medially. Laterally is the lateral head. And underneath the lateral head, and medial to it would be the medial head of the triceps. So here we can see the long head of the triceps coming off the infraglenoid tubercle. In other words, it crosses the shoulder joint, thus it must act at the shoulder joint, and it inserts onto the inferior margin of the scapula at the upper edge of the lateral border. Because it originates from the scapula and crosses the shoulder, it'll act at the shoulder and it'll be able to extend the shoulder a little bit when the shoulder is flexed. It could also give small contributions to shoulder adduction. However, at the shoulder, its primary function would be to extend the shoulder. The lateral head doesn't cross the shoulder, it only crosses the elbow. So does the medial head, it only crosses the elbow. The three muscles together form one muscle belly inferiorly and attach onto the olecranon process of the ulna. And the three together are the primary extensors of the ulna at the elbow joint. Once again, the back of the arm is served cutaneously by the radial nerve. Again, here we see that radial nerve coursing through the inferior parts of the axilla, spiraling around the midshaft of the humerus in that radial or spiral groove, and then coming back anteriorly. As it's looping around the humerus here, it gives off many cutaneous branches to serve the posterior arm, and ultimately even the lateral arm. And that concludes this discussion on the arm and the axilla. Please let me know if you have any questions or comments.